BioBalance Healthcast, episode 171, Postmenopausal Uterine Bleeding.
BioBalance Healthcast features conversations about positive aging. Your hosts are Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging, and Brett Newcomb, a licensed professional counselor.
Today we're going to talk about something that I run into every day of my practice and did even when I was just doing GYN, and that is postmenopausal uterine bleeding. That means you've got to have already gone through menopause, and you have to have a uterus. So those of you who don't have a uterus may not want to listen unless you want to listen for your friends. But postmenopausal bleeding is such a huge deal because it's a trigger for doctors. Mm-hmm. Doctors go, postmenopausal bleeding, because that is the only sign or the first sign of uterine cancer. So that's what they're thinking when they hear, oh, you're postmenopausal.
Yeah. It's like having a fire alarm go off.
Right.
Yeah.
So doctors immediately trigger to that, whether they be family practice, internal medicine, or GYN, and their job is to keep you alive. Our job is to keep you alive. So they think, I have to prove that this isn't cancer. So if they sound upset or like they are alarmed or anxious, it's because their job is to make sure you don't have cancer causing this.
Right.
And anybody can have uterine cancer after, and usually it's after menopause. So you can make your own estrogen in the fat, or sometimes when you take estrogen, then the uterus is the only organ that you really have to worry about cancer with taking estrogen, not orally, because it builds up a lining and the lining becomes abnormal.
Okay, so Angelina Jolie has the BRCA gene.
Yes.
And preemptively had her breast removed.
Right.
So that would never be a concern for her to have breast cancer. Mm-hmm. As a gynecologist, is there a gene that you can identify, and would you recommend a preemptive removal of the uterus for women that are worried about that or have cancer histories in the family, or do you just look at a case-by-case-by-case situation?
The American Congress of OBGYN does not give a guideline for family history of uterine cancer to take the uterus out. So it's not an indication. Or BRCA genes also show risk for uterine cancer, breast cancer, and colon cancer. So those three things, we don't take the colon out, and we're not. But the colon we need, and the uterus after childbearing is really the organ that we don't need. We still need ovaries if they're still well. Right. So I would suggest just watching it, and bleeding is the issue. If you were really afraid of that and you had BRCA 1 and 2, I would get an ultrasound of my uterus after menopause every year.
Every year.
And just look at the lining. We can tell with an ultrasound if it's too thick.
So don't rush to a surgery, but be aware that you have a risk potential and make sure that you and your physician monitor it consistently.
Right, and your physician probably will suggest that.
Right.
So, and I forgot to suggest ovarian cancer is in on the BRCA genes.
Yeah.
So it's very common for us to respond when we hear that a woman is bleeding after menopause by going, oh, we need to do some testing. And so that testing can be one of many things. It can be an ultrasound, which is what I always like to do before I did something invasive. If the lining is still really thin and you had some bleeding, there's nothing really to worry about except that it's messy. It's a hassle. So when we have, so we do an ultrasound, say it's thick, then I go to the next step, which is to biopsy the lining of the uterus. I don't perform those anymore, but I did all the time. So if the lining was thick, we'd put a little curette into the uterus and take a biopsy, send it off. If it's normal, then there's no treatment, except to do something to stop the bleeding so you're not bothered. But if there is something wrong, then we take the patient to a full DNC. And if that has cancer in it, then a hysterectomy. But it's the most treatable cancer.
So a dilation and
curettage,
which means you dilate them.
The cervix.
And scrape all of the lining out.
Right. Scrape or suction out the whole lining. So we use it looks like a a long-handled, like an iced tea spoon with edges that are sharp and kind of a hole in the spoon. But we use that to curette it all out.
Okay.
And then it's a very low-risk procedure, and you go to sleep just for a few minutes because it's very painful if you stayed awake.
Yeah.
So that's the only reason we would put people to sleep for that. And probably in 10 years we won't. We'll find something else.
Another way to do it, yeah.
But in any case, that's what your doctor's thinking of. Now that we've ruled out cancer, now that
Right.
we've decided, okay, here we have uterine bleeding, I deal with it now because I replace estrogen. Testosterone does not cause uterine bleeding, only estrogen.
Okay.
So when we give estrogen pellets, then anytime we get bleeding and we've ruled out cancer, we then have to figure out how to balance that estrogen so it doesn't make the uterus bleed.
When you use, I've heard you describe this before to women, and you use a lawnmower or grass cutting analogy that has to do with the thickness of the lining.
Right. I forgot about that.
Yeah. Can you talk to that?
So the lining in the uterus thickens and thickens and thickens until it gets so thick under the effects of estrogen that then it can't be held by the uterus and it just bleeds. It
Pieces tear off and fall.
Yeah, it cuts the grass.
Yeah.
It usually leaves some tissue in there that then grows again if you don't do something about it. So
Which is why a DNC is like having your yard resodded. They come in
Yes.
and scrape everything
That's
down
right.
to dirt, and then
Right.
they put new grass down.
right. But when the one hormone that balances estradiol is progesterone, not progestin, but progesterone. So we give natural progesterone with the estradiol so that the grass never grows.
Okay.
Okay, so if I do that from the very beginning, usually I won't have uterine bleeding.
I'd like to get like that for my yard.
Yeah,
Just,
well.
yeah.
Yeah, that'd be nice, wouldn't it? But it wouldn't be green very long.
No.
But in the world of postmenopausal hormones, any type of estrogen doesn't matter. In fact, pellets aren't even as common a cause of bleeding as other types of estrogen. But you have to take progesterone if you have estradiol being given to you so that the lawn stays the same height, you don't get cancer, you don't have bleeding, it's not a hassle. There used to be a theory by the men in the OBGYN field that everybody should continue to have periods if they took their estrogen, just to punish us for taking estrogen. So they thought we should take our estrogen and progesterone for 21 days and then bleed for 7 until we were 90. And I, of course, had to stand up in that lecture where I was, at that time, one of the few women, and say, you're wrong, we don't want to bleed the rest of our lives.
Yeah.
That's not what we want. And there's another way. So that was their way of emptying the uterus out. And my way is just don't build it up. So if we do have someone who, for some reason, builds a lining, and I do an ultrasound before people come in to make sure I know there's nothing in there when I start the estrogen, and then we can, if we have bleeding down the line, redo it.
I've learned so much from you about the growth of medical knowledge and the evolutionary change of medical practice. I mean, you talk about that was the standard of care. What you were taught in school is that women just bleed, and you just keep them healthy by letting them bleed till they're 90, or till they die, or whatever the time frame
Or
is.
they get sick of it and they
And-
stop taking estrogen.
And now the sense of what doctors are taught and what they do, that sounds so archaic and out of line. And
It does, because now half of the gynecologists are women.
yeah, you think that's the reason?
I think it is. I think it's because we entered the field, and now there's a lot of us. I was one of the first
Female
people,
gynecologist, yeah.
female gynecologists, but because we entered the field, we started saying, well, women, you guys have to talk to women and ask them this stuff, because then, in those days, no one said to their doctor, I'm not going to do that. They just
Yeah.
went out of the office and they said, yes, sir, yes, sir, and they threw their prescription in the trash as they left.
Yeah, I remember reading about George Washington was dying of pneumonia, and they kept using leeches, and they kept bleeding him because that was the standard of care.
Yeah, that,
And they had young
Leeches.
doctors there that were aware of a new procedure called a tracheotomy, but because they were young doctors and they were treating the father of our nation, they weren't allowed to touch him, so they couldn't do it.
They could have
And the guy
saved him.
died. Yeah, absolutely.
so the new ideas.
Was there and was life-saving, but it wasn't accepted yet.
And the reason they knew that may not have been that they were taught, but they knew that if there's an obstruction here, if you cut a hole here,
Right.
or excuse me, an obstruction here and you cut a hole here, then the patient will live because they know anatomy.
Right.
So a lot of the things that when a new treatment's given to me, I look at the physiology behind it, meaning the biology and how it works in your body with everything else
Right.
chemically. So
The law of unintended consequences.
right, I
Yeah.
take that treatment and say, like a new diabetes drug, how does this work? And which hormones and which hormones does
Yeah.
this alter, and how does it alter liver function, and how does it alter pancreatic function? And then, if that makes sense,
Right.
then I'm more apt to then try it
Try
with
it.
patients. And this is stuff that has been approved by the FDA, but many people aren't using it, like Victoza. So that's a diabetic
Because it's
medication.
a pre-diabetic medicine.
And a diabetic
And an actual diabetic
Mhm.
medicine.
It's the only one that makes you lose weight.
Yeah.
And that sometimes keeps you from being a diabetic.
Right.
Once you're on that for a while, you don't have to take it forever, because if you lose enough weight, sometimes in type 2 diabetes, you don't have diabetes anymore. So back to postmenopausal bleeding. So now you understand why people get so excited about it. And then patients get excited about it because they don't want it.
Right.
So our job is to somehow balance the progesterone with the estrogen. If they want to continue estrogen, they could stop taking estrogen and then just take testosterone in my office. Or, I mean, they have that option. Or increase the progesterone dose, or the way we give it, because it can be given as a cream, it can be given as a, we have one type of pill that actually bypasses the liver called a BLA progesterone. They could take it that way. There's no other.
Is that a sublingual, or is that something you just swallow?
It's oral.
Yeah.
One pharmacy that we know of makes it, and it works beautifully. We can use sublingual under the tongue, or buccal, which is like a lozenge that you put in your cheek or under your tongue before you go to bed at night. And that's the other thing. Progesterone makes you tired, and it helps you sleep.
So you take it at night.
You take it at night. You don't take it in the morning. I've had lots of people come from other doctors and, I'm so tired. Well, they're taking their progesterone in the morning.
Yeah.
So they're really chilled all day, but they don't get anything done. But taking it at night helps you sleep. So that's the idea. That's the hormone of choice. That's the hormone that also prevents uterine cancer. So what if somebody can't take this? I have some people who it makes them have the opposite. They bleed more. We don't know why.
Yeah.
We have no idea why that is. But sometimes it actually is something that gives them physical side effects throughout their body. So the answer is progesterone in a tiny amount that is put inside the uterus. And the way we do that is with an IUD. It's called Mirena. There's only one IUD with Mirena, and no, it's not for birth control when we use it this way. It is usually for birth control. But we use it in postmenopausal women who are taking estrogen, so that right inside the uterus, the estrogen will come from the bloodstream, but there's a little progesterone there, and it keeps the lining really thin. And it lasts 5 years. So it's huge. I mean,
So it's a sort of a spot-located filter that filters that out, so that the uterus doesn't continue to
grow
develop
a lining.
Yeah.
It's like putting the
But it's almost topical. I mean, the
it's almost
progesterone-
topical. It's
Yeah.
right
I knew I
next
wasn't
to
getting
the
right word.
lining.
Yeah.
That's exactly what it's like.
Yeah.
But you don't get it into the rest of your body.
Mm-hmm.
I have one patient that has really dry eyes. Progesterone makes dry eyes worse. Testosterone makes it better. So she gets an improvement with the testosterone, but she can't take the progesterone, and she's got a uterus.
Which is a good example of you're looking at the whole complex to say,
Right.
if we shuffle this, how do the dominoes fall over here?
Right, there are some symptoms that we have to change dosages so we avoid certain side effects.
Right.
And in this case, she did not want her dry eyes back. That was
Right.
not something she wanted because they were severe. So we gave her a Mirena, and that was it. She was better. So that's another option. Some women don't want to do that. They don't want something inside of them. That's their choice. So my last option for managing this is I have a few patients. They have to sign a release. But I will give them estrogen if they will get their ultrasound once a year and show me, I give them a low dose of estrogen, but show me that their lining is thin. So once a year, I look at their uterus and make sure there's no excessive lining.